Ji, Assalamu alaikum. This is Dr. Naseer here from SIAG. Today we are doing the APC for the solitary rectal ulcer syndrome. We have a 33 years old male patient. He was diagnosed as solitary rectal syndrome on endoscopy and confirmed by the biopsy. So today we are going to do his APC for the solitary rectal ulcer lesion. As we know that currently there are some studies which suggest that along with the medical therapy, along with laxatives, high fiber diet, toilet training, despite all these medical therapies, still they suggest that there is a role of APC for the SRUS lesions. So we have currently done nearly 18 cases of SRUS patient with multiple sessions for APC. So today we are doing this patient APC. As you can see that there are two lesions in the rectum just above the anal verge. Uh, we have set this patient a power of 40 watt and the gas was 1.8 per liter per minute. So we are doing this patient APC. As you can see that APC, you have to be very close to the mucosa, but you should not be touching the mucosal surface because it is a non-contact method. When you touch the mucosal surface, there are chances that the scope opening might get blocked by the coagulation that is happening. For those students who are nearly doing their training, they might be having APC at their center. So it will be a learning curve for them as well, that how we do APC for the solitary rectal ulcer syndrome patients. जैसे आपको पता है कि आमतौर पर APC हम लोग करते हैं जितने भी म्यूकोजल लीजन, ख़ास तौर पर गेव के लिए फॉर CLD पेशेंट, अदरवाइज CKD पेशेंट, we can do for angiodysplasia, we can do for bleeding control as well. But as I earlier told you that this is now currently being done for SRES patient as well. So you can see I am using basically the OGD scope for this lesion because OGD scope is much flexible and has much more control to do the APC, because you need your scope needs to be in different position to precisely and do the APC. As you can see on this, I am doing it just close to the lesion. My scope should not be, or the probe should not be more distance. If the distance is more, it will not do the PC, or if the distance is too much close, it will also will not be helpful. So your distance should be 2 to 5 mm from the mucosal surface. As you can see here, we are doing it all the ulcer that is present over there in the surrounding mucosa. We will try to ablate all the ulcer lesion. So along with this, we will also advise the patient the medical therapy, that is laxatives, arsenic enema, high fiber diet, constipation relief, toilet training. All these are also advised also to these patients. ये आप देख सकते हैं इस वक्त APC हम लोग कर रहे हैं. It is happening very well. All the serious lesion that was there, it is nearly being done. और दूसरी एक चीज़ ये भी ज़हन में रखना है अपने, ख़ास तौर जो स्टूडेंट्स हैं उनके लिए, शायद जो लोग अपने सेंटर्स में नहीं कर रहे हैं, इट इज़ वेरी सेफ, वेरी इफेक्टिव for these patients. The only thing that should be kept in mind that while doing APC, there might be some ear insufflation, especially this argon gas can cause distension of the colon, and patient might be feeling some. That's why I have removed this and tried to suck all the air and the gas that was being insufflated inside. तो इस गैस को हम लोग कोशिश करते हैं कि इंटरमिटेंटली दरमियान में डिफ्लेट कर दे, ताकि सारे सक्शन के ज़रिए आर्गन गैस जितना हमने इंसर्ट किया उसको रिमूव किया जा सके. क्योंकि देयर आर चांसेस, देयर आर सम स्टडीज दैट माइट से दैट देयर आर चांसेस के बर्स्ट होने का चांस होता है, परफोरेशन माइट अकर ड्यू टू द आर्गन गैस विच कैन इंटरेक्ट विद द कोलोनिक gases or the feces that is there in the colon. तो इसीलिए ख़ास तौर पर एक और चीज़ जो मैं बताना चाहूँगा कि these patients should be advised full colonoscopy solution. The colon should be clean because there might be interaction with the colonic gases and it can cause burst consumption. So it is important you should have a clean bowel, and along with that clean enema should be given before the start of this treatment. Now you can see that almost nearly 60-70% of the surface has been coagulation has been done. Few areas are left. We will try to do the coagulation here as well. You can see, you can appreciate that I am turning my scope towards that area. And there are another important point is the probe which I am using. These are basically can be there in three types. One is this, the front, it can the gas can be released from the front, and another one is from the side, which has a side opening side, from it can release from the side, and the other one is circular, it can release all around the probe. So there are three types of probes for this APC. As I earlier discussed, the different settings are there for APC according to the lesion. When you have gave lesion, it is different setting. When you have controlling bleeding or tumor ablation, so different types have different settings. So each you should know that which setting should be used for which lesion. And now you can appreciate that almost nearly we have done complete APC of this solitary rectal ulcer syndrome, and we will try to repeat this procedure after every month for at least 4 to 6 sessions.